We are live, sir. We can start, sir.
Good evening, everyone. I'm Dr. Sivashish Dey from ResMed, and I welcome you today evening to this session on low-touch sleep diagnostics in current time. So today in 1 hour time, maybe we'll discuss on, the newer diagnostics which are available during this pandemic time. And I'm sure with our, respected faculty, Dr. Jagdeep Bijwadia, we will gain, a lot of knowledge and enlightenment on how has been the diagnostics shifted in the current times. So with this, let me start this session with a short video. I hope you will enjoy the video.
Is snoring a part of your routine? Do you miss the freshness of a healthy sleep? Do you wish to find answers on how to improve sleep? To improve your sleep, you must learn about your sleep quality. Here's a simple, accurate, and a safe way to analyze your sleep quality. One sleep test, a small test that can bring a big difference to your sleep health. In this disposable kit, you will find one night owl sensor, 10 single night finger wraps, and one user guide that makes everything easy for you. Download the Night Owl app, enter the activation code, and you're ready for one sleep test where everything happens with minimum effort. Wrap the sensor around your finger as instructed. Keep your phone at a safe distance in the same room and sleep without any worry. Repeat this multi-night test for 3 days. One sleep test based on peripheral arterial tonometry technology provides an accurate way to diagnose your sleep health. The Night Owl sensor measures key indicators like heart rate, oxygen levels, total sleep time, and body movement to determine the risk of sleep apnea. In 3 to 5 days, you will receive a detailed report validated by a sleep physician. One Sleep Test is a US FDA approved device for measuring sleep quality by using AASM standard for scoring. And it is the most simple, accurate, and safe way to perform diagnosis in the comfort of your home. Once you have your sleep assessment reports, you can take the next steps to sleep better. Get a free sleep consultation from ResMed sleep coaches who will guide you towards a healthy sleep. Bring home ResMed One Sleep Test today and start your journey towards a healthy sleep. Wake up to good sleep.
So hope you liked the video, and thanks for attending this session on a busy evening, I guess. And if you look at the agenda, we'll start off with the topic low touch sleep diagnostics in current times by Dr. Jagdeep Bijwadia, which would be followed by a Q&A session. And post that, I'll take you through a few slides which talks around one sleep test and where we can use this particular test. And last but not the least, we will have the closing remarks. So I would like to introduce our esteemed faculty for tonight, Dr. Jagdeep Bijwadia, sir. So Dr. Bijwadia is a board certified physician in internal medicine, pulmonary medicine, and sleep medicine. And he is currently based out of Minnesota in the United States. He also holds a faculty position as assistant professor in the Department of Pulmonary Critical Care and Sleep Medicine at the University of Minnesota. And he has served as a director of sleep program there till 2012. Interestingly, he is also the founder and CEO of SleepNetRx, which is a large telemedicine platform, and also serves as the Chief Medical Officer for Whole You and Better. So these are all organizations based out of the United States. So he has also been named as the top dog by the Minneapolis magazine, as well as the US News and World Report. He is also the past president of Minnesota Sleep Society. Dr. Bijwadia is also a well-recognized speaker, and in the recently concluded 2020 AASM Annual Congress, he was the speaker cum panelist on the course for consumer sleep technologies. So let's hear from him, the low-touch sleep diagnostics in current times. So over to you, sir.
Thank you so much. Let me just get my organized here. I'll share that. Can you see my screen?
Yes, I can see your screen.
Okay, perfect. So thank you for that that very kind introduction. You know, I've been in the United States for many years and obviously done a lot of talks in the US, but this is actually the first time I'm able to have a sleep conversation and a lecture in India. So I'm extremely excited and thrilled and pleased. I'm a little jealous because right now it's about 25 degrees centigrade here, so it's Fahrenheit here, so it's quite cold, hence the sweater. But it's very nice to be on this panel, and I'm going to be talking a little bit about the new technology with the onesleeptest. I recall the time when I was just finishing up my sleep fellowship in 1996, and we had these huge reams of paper that we had to go through. Each study would measure about 2 or 3 pounds in weight. And now it's come to this incredible technology where you can take a little device home and within a day get the final diagnosis. So we've come a very long way, and it's been fun to be part of the journey. So I'll just start trying to advance the slide here. Okay, so I think we can start with just the fundamentals of what the onesleeptest is. And really, as you know, especially in today's climate with COVID, we really need to have low-touch diagnostics where we're not exposing our patients or ourselves to any sort of infection danger. But even apart from that, even after this crisis goes, I think the simplicity of being able to perform a sleep study in the comfort of your own home within a night is really something that's quite revolutionary. We'll go through some of the clinical principles of operation of the device itself. We'll then dive a little bit into what the signals look like. What exactly are we analyzing, and what can we conclude from the signals we get? We'll talk about how these signals were validated on a clinical basis through the submission to the FDA, and how the signals have been validated for accurate diagnosis. And then we'll leave some time open for Q&A. So let's get started. As you know, with the global pandemic, the American Academy of Sleep Medicine had a paper out in April of 2020 that basically advised sleep physicians, because of the pandemic, to consider using single-use, fully disposable devices when possible. I know in the United States, for example, in Minneapolis, the University of Minnesota and many of the other sleep centers that did inpatient sleep studies were closed for at least 3 months. And even now that they're open, we still don't do any titration studies. The AASM recommends to try and use a HST delivery service so that there's no touching of the patient. Try to use the devices that are easy to clean and sanitize. Ensure that the patients don't have to return the device back and forth to your office if possible. And do as much instruction as possible using technology. So brochures or videos. And if you think about the night one and its workflow, where the patient just gets a packet at home, connects it with their cell phone, and everything goes up to the cloud. it meets all of these criteria and more. So it's a very user-friendly device that meets the criteria that were laid out. Because obviously today, especially with COVID, there's some very significant challenges that we face. We have to deal with, contamination protocols. If there's a sleep lab, we really want to try and move to a digital first delivery. The one sleep test also allows us to limit capital investment because sleep studies can get very expensive in some situations. It allows us to reach patients that are really in remote locations. So even if a patient is, 100 and 150 miles from our sleep centers, we can just give them these little devices, and we can get all of the information we need within that night. And lastly, the deployment of the device and the scoring is all automated. So it really doesn't burden your own staff. So this is something you can use within your practice, as I do every day, in a very simple way without too much burden. So as you can see, the device itself is a little miniature device that goes on a digit or a finger. And it gets wrapped with a little Band-Aid type device. We should remember not to make it too tight. It just has to be enough to keep the device on. And the one test, it's manufactured in Belgium by Ectosense. We have actually the two founders of Ectosense on this webinar with us, and certainly happy to give you some information if you have any questions afterwards on an engineering level or technical basis that they can answer for you at a later date. The device is currently available in the United States, in Europe, and in Japan, as well as Australia. So it's classified as a Class 2 medical device by the FDA in the United States. It's FDA cleared. It also meets all of the ISO manufacturing standards. So it's certainly something that's deployed widely in the world right now. It's multi-use. So unlike some of in fact, any other home sleep test, which is you can deploy it only for a single or maybe 2 nights at the most. This you can deploy over multiple nights, which has some advantages that we'll go over in a little bit. The key outputs are the surrogate of the apnea-hypopnea index called the PAHI, and I'll explain a little bit more about that as we go along. It tells us about the total sleep time, as well as the oxygen desaturation index. All of these are critically important for diagnosing sleep apnea, as you well know. The device is based on peripheral arterial tonometry, which is a reflection of the sympathetic tone in the body. We'll talk a little bit about that as well. And it is considered a level 4 device, which has its own classification, but considered as a level 3 equivalent in most cases. And it has been validated by significant studies that will go over some of the data so that we know what we're looking at is accurate. So what is the technology and how does it work? Well, as you know, with obstructive sleep apnea, the basic issue is that the upper airway becomes unstable as we fall asleep at night. And as our muscles relax, all of the muscles holding the upper airway open relax as well. And so the airway can collapse on itself. And as soon as the airway collapses, the brain sort of realizes something's wrong because your oxygen levels are dropping, and it causes what's called an arousal. And that arousal causes a whole series of events. So this particular device can analyze the blood oxygen levels, the pulse rate, and the peripheral arterial tone, all of which change after an obstructive apnea. And I'll explain a little bit more in detail how that occurs at the end of every event. The device also measures actigraphy, or the motion of the body through an accelerometer on the finger, as well as blood oxygen saturations. And it is a combination of these signals that give us the diagnosis of obstructive sleep apnea in these patients. Peripheral arterial tonometry, I should point out, doesn't directly measure the airflow like other devices do, but it's a surrogate measure. And we'll talk about how an obstructed airway sets off a series of physiologic events that are very predictable and that can be picked up by this little device. Lastly, all of the data and signals are put through an automated analysis software. And so once the study is done, the data all goes up to this automated analysis software, which gives a very accurate reporting of the apnea index. And we'll show you an example of some of the reports. So peripheral arterial tonometry as a technology to measure sleep apnea is not new, okay? The AASM guidelines in 2017 included peripheral arterial tonometry with actigraphy as a validated measure and is included in the HSAT guidelines. The American Academy of Sleep Medicine scoring manual also talks about using PAT. So it's a very well recognized technology. I think it's estimated that about 20% of the sleep studies done in the United States today are with the PAT technology. So very well sort of accepted in sleep circles around the US. This next slide shows you about how peripheral arterial tonometry actually works. So when our airway collapses, as I mentioned, the brain recognizes that something is wrong because your oxygen levels are falling, and it causes an arousal. And that arousal increases the sympathetic nervous system activity right at the end of the respiratory event. And that increased sympathetic activity results in an adrenaline-mediated digital vasoconstriction at the digit blood vessels, which can be recognized by this device. When the digital artery constricts, there is reduced blood volume, and that can be picked up by the sensor, the fact that the blood volume is decreased. And as you can see here in this particular slide, when the blood vessel is fully dilated, there's a significant amount of signal, but as the blood vessel constricts, you can see an attenuation of this signal or a decrease in the PAT signal that is picked up at the end of this respiratory event. So the PAT signal really is based on an extended analysis of the PPG, or the peripheral signal that we're looking at here. I'm sorry. So what happens is that a light source, an LED light source, shines light into the tissue, and the light detector, which picks up the reflected light, picks up how much light is being reflected back after passing through the tissue. So obviously during systole, when the tissue is more perfused, more light is going to be absorbed by the blood, resulting in a lower signal that is detected by the light detector. So higher the volume of the blood in the tissue, the lower the PPG signal, and vice versa. So it's very similar, and the technology is very similar to what we use for pulse oximetry, which many of you might be familiar. But of course, the signals are processed very differently to arrive at the PPG signal. So this slide is a little bit more detail of how a respiratory event is detected and analyzed. And I'll take your attention first to the airflow signal, which is right here. You can see that this particular event is showing that there's no airflow. So when the airway is collapsed, obviously there's no airflow going to be detected at the nose, right? So that's what an apnea looks like, or loss of airflow. Now, when the patient's airflow starts again, it's called a sudden opening of the upper airway. And when that happens, two things occur. One is that the peripheral arterial tonometry signal picks up the fact that there's sympathetic activation. And so there's a decrease in the signal of the PAT, right? And when the airway is collapsed, there's also a desaturation. So at the end of every apnea, your oxygen levels fall and your pulse rate rises. So you can see the fall in the oxygen level here associated with the increase in the pulse rate here. I'm sorry. So this combination of signals which is the decrease in oxygen levels, the increase in the pulse rate, and the attenuation of the PPG signals. This combination of physiologic signals tells us that there has been an apnea event, and that is counted in the device. And it occurs with what's called a probabilistic model. And so because we're not measuring airflow directly, we're measuring it indirectly by the sympathetic surge and the increase in pulse rate activity. But as you will see, that this surrogate of airflow gives you an extremely accurate count of the number of respiratory events occurring per hour in anybody with obstructive sleep apnea. So when should we be careful about this particular technology? Well, one thing is for sure that because we're measuring peripheral arterial tone and the constriction of the blood vessels, if you have conditions that are going to impair the sympathetic response or impair perfusion at the peripheral fingertip, that's going to decrease the signal quality. And so those signals will be discarded, and this particular technology may not work very well for those people. So an example would be patients who are using alpha adrenergic blockers. This will prevent, obviously, vasoconstriction. Or patients with severe peripheral vascular disease like severe Raynaud's phenomenon, for example. So in these patients, if you use the OneSleep test, you probably will not get good signals, and those signals will be discarded. And therefore, it's not really a safety issue, but it's just a fact that you probably wouldn't get good readings, and it's probably not indicated to be used in those particular circumstances. I pointed out earlier that one of the significant advantages of the OneSleep test is that you can do multiple nights of testing. Now, why is that necessary? Well, one is that there have been some really interesting recent studies that have shown that if you do just a single night test, a third of patients with mild to moderate sleep apnea might be misclassified or misdiagnosed. So if you think about it, obstructive sleep apnea is worst when the patient is in REM sleep or if they're on their back, right? So there might be a particular night where the patient has not gone to their back or hasn't gone into REM sleep. That would be one reason why a patient may not be diagnosed with obstructive sleep apnea, even though they have it. So if you do sequential nights of study, now you're going to pick up those nights where the patient is going into REM sleep or going on his back, or they have a poor sleep efficiency. So doing multiple nights of study tends to increase the likelihood of picking up this problem. So another study found that a patient with a negative single night test would have been diagnosed if they had a 3-night test. So 50% of those patients would have been diagnosed if they had a positive 3-night test. And of course, multiple night testing also allows for the possibility that if one night had maybe bad data, you can eliminate that issue by just doing more nights of study. Certainly doesn't add to the cost. And lastly, in the United States, for example, we do treat sleep apnea with dental devices, where the jaw is slowly moved forward. And in those cases, using multiple night study helps you decide which is the optimal position for that dental device. Lastly, one of the things I've seen is that just from a practical standpoint, when you do a home sleep test, the patient might come back the next day and say, doctor, I didn't feel that night was a good night. It wasn't representative of what I normally do. So if you can tell them that, hey, we've studied you for 2 or 3 nights or 4 nights, now all of a sudden it builds confidence in the fact that, you really do have a problem. Night after night, I am seeing these apneas, and therefore I probably do need treatment. So it does help to motivate a patient even to pursue treatment after the testing is done. So what about some of the deployment considerations? Well, one of the things for us to remember is that because there's no direct respiratory effort measurement, we cannot really differentiate a central sleep apnea. So if somebody is suspected to have central sleep apnea, for example, if they have severe congestive heart failure, or they're on opiate pain medications, or high altitudes, then I think this would not be the correct test to do. Also, because we're not measuring airflow directly, there's no differentiation between apnea and hypopnea. So that is something to remember. Now, on a practical level, that doesn't make too much difference, because if your combined AHI is accurate, that's really what we base our treatment decisions on. Obviously, there's no EEG-based sleep stages. So if you really want to know if a patient has gone through different stages of sleep, you might want to consider in-lab polysomnography. So those would be situations where this particular technology would not be useful. Again, take note of the contraindications we talked about, alpha blockers and peripheral arterial disease. We talked about that. In general, I would say that if you have a very complex patient, severe COPD, congestive heart failure, they have, multiple complex arrhythmias, you probably want to pause and say, well, this is probably not the right test for them, and then move on to an in-lab treatment. But the strengths, of course, is that in, I would say, 80 to 90% of patients with straightforward sleep apnea, this is a highly accurate test that can do multiple nights of study in a very cost-effective manner, which is very comfortable for the patients to do. Let's look at what these signals actually look like, or what these reports look like first. So this is a simple one sleep test report. It's called the Night Owl in the US, but it's going to be very similar. You can see here that right on top, there'll be a few patient demographics, the patient, who the patient is, their ID number, date of birth, things like that. It'll tell you when the recording started and ended. You then move over to the apnea-hypopnea index, which of course is an indication whether the patient has sleep apnea or not. You can see in this green zone, if the patient has an apnea-hypopnea index less than 5, you shouldn't have to worry. That patient does not have sleep apnea. And then you can categorize the sleep apnea as mild, moderate, and severe according to the AASM guidelines. So 5 to 15 would be mild, 15 to 30 would be moderate, and more than 30 would be severe. And you can see in this particular patient, it's very easy to visualize that this little line here tells you that this patient's apnea-hypopnea index is 26. You can see it down here. That's put them in the moderate sleep apnea range. So with a single visual, you can tell whether this patient has sleep apnea or not, which is pretty easy to tell. It'll tell you how much of the recording was rejected because of bad signal. The pulse rates are here. So it'll tell you what the high and the low pulse rates are. It'll tell you what the oxygen saturation was throughout the night. So ODI is the oxygen desaturation index, how many times the patient's oxygen fell by at least 3 or 4%. And you can tell the number of times that happens. You can tell the minimum and maximum oxygen saturation levels through the night. And lastly, the last panel tells you about the total sleep time and sleep efficiency. So if somebody has less than 4 hours of sleep, you might want to say, well, I want to repeat that study to look at a more detailed analysis. This is what the actual PPG signal looks like in somebody with obstructive sleep apnea. And I'll point out just a few features. On the top panel is the saturation monitor, which looks at, you can see that the saturations are pretty stable for the first little bit in the study. And then you can see that the oxygen saturation start dropping. And these red lines over it indicate that the device has counted these as apneas, not only because the oxygen levels have fallen, but they look at the totality of the signals across all of the panels that we'll just go through. So, but you can see here that there seems to be, areas in the sleep study where the oxygen levels are falling. This is the PPG signal itself. And you can see that when the oxygen levels fall, there's this variability or drop in the PPG signal. It may not be very obvious here because it's a very contracted signal. We're looking at a 12-hour sleep period, but I'll expand that in the next slide and you'll be able to see it a little bit better. This is the pulse rate, and you can see as the oxygen levels drop, the pulse rates tend to rise. And this is something that we pointed out earlier, that this physiologic change is what is picked up on the particular monitor. And then lastly, this is the actigraphy or activity monitor. And all of these red lines, as you can see, tell you when the device is picking up these as apneic events. Now we're taking this same signal and moving it out to about an hour. So you can see here that the saturations were just fine and the PPG signal looks very regular and uninterrupted, as you can see here. And the pulse rate also seems very stable, right? But in the two sections in the front and the back of these panels, you can see here that the oxygen levels are continuously dropping as the patient breathes. Each one of these little gaps is a breath. So you can see that the oxygen levels are persistently dropping. Every time the oxygen level drops, you can see that the peripheral arterial tonometry signal falls. So unlike this very stable PPG signal here, you can see here that the PPG signal seems very irregular, right? And lastly, you can see these pulse rate increases with every event as well. So this whole pattern of dropping oxygen levels, decreasing PPG signals, and increasing pulse rate is what will define the number of apneas. And this is very easy to see in this particular panel. So how is this technology validated? How do we know that these combination of signals is actually very accurate? And the onesleeptest device, or the night owl as it is called in the United States, was validated first in a paper published at the JCSM in 2018 with 101 patients. And what they did was they did a in-lab polysomnography, so an actual sleep test with the night owl device in place. So they did both of those studies simultaneously and in parallel. And one of the unique features of this paper was that every polysomnogram was scored not only by the lab in which it was performed, but all of the data was de-identified, all the annotations were taken out, and it was given to another lab that completely independently scored these polysomnograms. So that really increases our confidence level that these studies were done very well. And then a second paper is being prepared for submission right now. It hasn't been published yet, which basically took the similar study design, increased the number of patients to 160 subjects, similar trial design, but they also added some subgroup analysis that we'll talk about in a little bit. And essentially, the bottom line is that it did confirm the reproducibility of the performance metrics. So this is a visualization of the study here. If you look on the right-hand side, here's a patient who's undergoing both polysomnography as well as the night one sleep test, or night owl as it's called. The polysomnography data was then analyzed, as I mentioned, by two different labs, the Zoll analysis lab and the MSS. These are just abbreviations. These names are in Belgian, so I'm not going to butcher the pronunciation, but two independent sleep centers analyzed those. And each one of these was compared to the automated analysis by the night owl. That was the very, very elegant, tight design of this study. You can see here in this correlation analysis that when you compare the respiratory event index or what's called the derived PAHI with the night owl with the apnea hypopnea index that was measured by the first lab, the MSS lab, you can see a pretty linear correlation with a correlation coefficient of 0.87, which is of course the coefficient of variation is less than 0.001, which is very, very accurate. And this was the same when you compared the two polysomnography labs. So if you compare one polysomnography lab to the other, it is about the same as comparing the night owl to any of the polysomnography labs. So this is a very accurate way to look at the analysis. One thing I will point out, though, is that when we look at the total sleep time, the correlation is not as tight. So the two sleep labs had a pretty linear correlation, and they agreed with each other quite well. And the night owl, the scatter plot, as you can see here, is a little bit wider. So the correlation is about 0.78, which is still good. But what I would say is that if you really want to measure somebody's sleep efficiency, sleep time, and sleep stages, you really want to think about a polysomnography at that point. So again, looking at the categorization agreement, which means how well did this device differentiate between mild, moderate, and severe sleep apnea. You can see here that the categorization agreement was pretty good with the REI for the night owl was 0.812, which was actually better than comparing the two polysomnograms together. So that is, it's pretty good at categorization. Going quickly into the 2019 study design and main conclusions, again, this was a larger study with about 160 patients that had suspicion of OSA. Multicentric, so it was 3 centers in the United States as well as 1 in Belgium. Similar age, BMI and AHI distribution as to the 2018 study. Same design with double scored design as we talked about. Here we had some interesting subgroup analysis. So, the FDA wanted lightly pigmented versus darkly pigmented skin. So there were group analysis of that. Periodic limb movements, some patients had it versus not, and how does that affect the signals? We had to study that. What happens if there's significant cardiac arrhythmias versus patients with no cardiac arrhythmias? How does this device perform? So all of those subgroup analysis were performed. And I would say that the take-home point is that the study confirmed reproducibility of highly similar performance metrics to the 2018 study. So everything was confirmed. Again, this is not published data, so I just want to emphasize that point. But there were really no relevant performance differences between these particular subgroup analysis as well. Just a quick thing, this is a summary statistics on the pool data set of all 264 patients in both studies. Again, we're not going to go into the details of the non-published data, but you can see here that the category assessment and the sensitivity and specificity were really excellent. When you look at the pool data with 0.97, 0.93, and 0.91 sensitivity and similar ranges of specificity when you looked at the AHI at the various categories of AHI here, 5, 15, and 30, mild, moderate, and severe sleep apnea. So I'll end here. Hopefully that's given you a little bit of an overview. I will say that I've started using the Night Owl in my practice, and it's been, an extremely, the patients really have liked the fact that they can do this in their own home in a very easy fashion. So I'll open myself up to questions, and Shivashish, I'll stop the share here.
Sure. So thank you so much, sir, for taking us through your presentation and giving us a 360-degree overview of onesleeptest. And there are a lot of questions which I can see in the chat, and if I can start with one of the basic question for any sleep diagnosis. So one of the question is, what are the drugs or medications or lifestyle things like smoking or alcohol? What are those things which you shouldn't take before initiating a sleep study? So if you can highlight those factors.
Sure. Yeah. And, we get asked this a lot. So when a patient comes into our sleep center, what if they have, a glass of wine before going to bed? Or what if they have certain habits or things that they normally do? We normally say that try to keep to your most normal routine. And the reason we do that is, let's say somebody is used to having a glass of wine at night, and that's causing sleep problems and apnea, right? If you tell them not to use it, you're now going to miss the diagnosis. Now, the treatment for that particular patient might just be stop drinking wine and see what happens and repeat the test. But we always want to try and do the same thing. Now, having said that, if somebody is on a short-term course of, let's say, pain medications, you probably want to take them off that before doing the test. The real clinical pearl is try to do the sleep study in the patient's most natural sleep state. Would be my advice on that.
Sure. So I think we can avoid that one glass of wine maybe if we are trying to initiate a sleep diagnosis, and of course take care of other factors which might impair that particular night's sleep. So that's one question. I think there are a few other questions which has come from the audience. One of the question is that, suppose, you're talking around, so this device is based on PAT technology. And what if there is a patient who is having severe COPD, or maybe a COPD with, OSA overlap, or maybe having, severe case of ILD, so
Sure.
what's your suggestion on those particular cases?
Absolutely. So I think that whenever you suspect somebody has complex sleep-related breathing disorders, right? And I think you gave a few examples. COPD would be one, where you're worried about nocturnal hypoventilation as well as REM sleep-related sleep apnea, right? So those would be situations where the night owl would not be able to give you the data that you need. Similarly with ILD, you're looking for tachypnea and low tidal volumes. Patients with central sleep apnea, for example, if they're on opiates. If patients have post-stroke, for example, where you're worried about biotes breathing or periodic breathing. In all of those categories, you really should not be doing not only just the one sleep test. That I would say don't do any home sleep test. Those patients should actually be studied in a sleep center. Now, in the real world, that accounts for about 10 to 20% of patients. So if you look at the average number of home sleep tests versus in-lab sleep tests done in the United States, it shifted significantly. And now I would say about 70% in many centers of all sleep studies are done as home sleep tests.
Yeah, and I think, sir, the ASM guidelines are also particularly very clear that comorbid conditions which are very severe, so perhaps those are the cases where we should go for a in-clinic diagnosis
Absolutely.
rather than home sleep test. So I think that makes it all the more clear on that front.
Right.
So this is one question, which what we should avoid. But given this is a new technology, I think there would also be questions that how do you choose patient to put someone on this particular technology, or go for a home sleep test with this technology? So what's your practice like?
So, typically, obviously, you have to have a clear suspicion that this patient could have obstructive sleep apnea, right? I think one of the issues is awareness and education. I think, if you think about snoring, a lot of people, pass that off as something normal, right? Yeah, I just snore. It's not a big deal. Wake up. I think if you have somebody who's snoring as well as feeling fatigued and tired during the day, or waking up poorly rested, especially if they're waking up gasping, or if somebody is telling them about pauses, you should absolutely think about, could this be sleep apnea? Because it has so many repercussions for their health down the road. So I think just being very aware and educating the patients that, hey, this is something that is common, it's correctable, and it's dangerous if you don't treat it right. I think that awareness has to start at the office. Now, once somebody is, has been suspected to have obstructive sleep apnea, at that point, if they don't have any of the complex comorbidities that we talked about, I think the next step should be a home sleep test. So it's a very logical progression, and I think for us, the main issue that we deal with in the United States, and I'm sure even more so in India, probably is the fact that we have a large number of undiagnosed patients that are just suffering, and nobody is able to take them through those steps. So hopefully this technology allows us to reach more patients and create that awareness as well.
Yeah. So I think if I can summarize, maybe those 10% cases which are really, on the lower end of the spectrum, having a lot of
Mhm.
criticality, possibly those are the cases which are not the right fit patient for a home sleep test or one sleep test like this. But then majority of the patient could be tried through this particular device. So,
Yeah.
so I think uh, there is another question. It's a bit of a complex question. So
Yeah.
someone is asking that how much of internight variability in AHI can one expect? Or rather, have you seen any AHI variability as such? And if a person falls in two different categories of severity, how do we manage the therapy then?
Yeah. Great questions. So let's start with the internight variability. So the apnea-hypopnea index really can vary because of three reasons, right? One is if your sleep efficiency is different on 2 nights. Number two is if your sleep stages are different, like one night you went into REM sleep more than the other night. And lastly, if your body position is different on 2 nights. So one night you slept mostly on your side, the other night you slept mostly on your back, right? So because of these variabilities, every night there can be a difference in the apnea-hypopnea index. Now, there have been studies that have been done in the past with polysomnography, looking at what is the common sort of AHI difference between the various nights. And it's somewhere between 10 and 20%. So in other words, if somebody has moderate or severe sleep apnea, it's very unlikely that repeating a test is going to change your diagnosis. If on the other hand, somebody is borderline, right? They have an apnea-hypopnea index of 4, then it's possible that if you repeat another night or two, because of that 20% variability, that you would be able to diagnose them with mild obstructive sleep apnea, right? Now, in terms of therapy, and what does it mean if mild, moderate, or severe, what does it matter? Well, a lot matters, because if you have mild sleep apnea, your therapeutic options start opening up, right? So if patient has very mild sleep apnea, you might want to tell them just sleep on your side, lose weight, elevate the head of your bed, use nasal decongestants. That might be all that's needed. But the more severe your sleep apnea, the more likely it is that now you're going to try different things. Maybe for mild sleep apnea, you could try a dental device, right? Maybe, but if you have sleep apnea, which is symptomatic, for all levels, CPAP is an option, right? So because CPAP works at every level of obstructive sleep apnea. So I think for patients with very severe obstructive sleep apnea, you would not be talking to them about dental devices. Not that they shouldn't lose weight. Of course they should lose weight, and it still helps to, do those things. But you're going to look for, therapies that are going to impact that severe sleep apnea more directly. So I think categorizing the patient correctly does make a lot of difference when you think about those therapeutic options.
Sure. So I think, I could find these key questions from the audience, and, I would ask the audience to keep on, sending their questions. So that, and questions, I think, relevant to the topic which we are discussing. And then we'll take it up, at the end of this session again, probably. So with that, let me share my screen, and let me give the audience a brief overview around the onesleeptest, the device which we have launched today. So if you look at onesleeptest, as illustrated in the previous session, we have learned around the different, uh, the regulators which has approved it. We have gone through the clinical trial data which is available to us, and of course we have learned around the clinical intricacies of using this particular sleep test. So if you look at onesleeptest, this is a simple, accurate, and a safe way to start tracking one's sleep and to diagnose sleep health. And if I can give you, few particular features of this particular device. So this is a disposable multi-night home sleep test device. And as explained by Dr. Bijwadia, this is based on peripheral arterial tonometry technology. So again, we have seen in the previous lecture that it has been validated against INLAF PSG, and the study came out in JCSM in 2018. In addition, this particular device has been approved or cleared by European CE, the Therapeutic and Drug Administration in 2019, and US FDA in 2020. And Ectosense from Belgium is the manufacturing of this device, whereas ResMed is the sole entity which is marketing this device in India. So how does the device looks like, or what it comes up with? And if I can give you the product characteristics. So if you look at this pack, this would come with one night owl sensor, 10 finger wrap, and one quick start guide. So these are the constituents of onesleeptest device. And when we look into the specification, this is a single person use device. Of course, disposable, but has to be used in any individual who is over 18 years of age. And the shelf life of the device unopened is 4 years. What about the clinical studies? I think we have already looked into the published clinical study by Frederick Massey, which was published in JCSM in 2018. And we have seen the close clinical correlation between the one sleep test with night owl sensor with the in-lab PhD results. In addition to that, let's also look into the regulatory approvals. So this is the snapshot of the US FDA, which has approved the night owl sensor as a wearable device uh, to aid in the evaluation of sleep-related breathing disorder in adult patients, particularly who are suspecting or are suspected of sleep apnea. So this device also has the European Commission certificate or the EU approval, as shown here. And further to that, we also have the One Sleep test also has approval from the TGA or the Therapeutic Goods Administration, which is equivalent to the regulatory agency of the Australian government. So in a whole, I think this is one device which has good amount of regulatory approval, and as Dr. Bijwadia mentioned, it is present in most of the present in US. It is right now present in Europe, Australia, and in Japan. And right now it is available in India. So uh, we have talked around the science part of the device, uh, but let us also look into how the patient journey looks like. So what happens if someone gets a one sleep test and how the journey would look like. So suppose a patient or a customer buys a one sleep test from one of the channel partners. What typically happens is, uh, you know, this is how the packaging looks like when you get it. And uh, at the same time, the customer is given the instruction that you have to download the Night Owl companion app from the Play Store or the Apple Store into your um, smartphone. So that has to be downloaded, the Night Owl companion app. And post that, there is activation code in the uh, OST or One Sleep Test package, and you can basically scan that particular activation code through your smartphone and activate the device. So when you activate the device, you see this particular screen where we take an informed consent, because this particular app will also capture the customer demographic data, which includes name, email ID, phone, and the age of the person. And post that, there are a sequential series of short videos which actually tells how to wrap this particular device onto your fingertips uh, using a tape which is provided. So there are 10 strips, adhesive strips, which are provided. So that is something which is very self-explanatory, available in the app. So after wrapping the device, the app gives an instruction, or rather, ask you 3 questions, which includes that, how long do you think it took for you to sleep once you started the recording? How many times did you wake up at night? Were there any factors affecting your sleep last night? So these are the questions which you'd be asked when you wake up the next day. And these are very important questions because it helps understand the report by the doctor. Suppose that you get a notification that your test was successful, and of course, if the app needs more data, it will give you a signal that okay, we need more data on this. So this particular process happens for 3 nights, and if you feel that you want to ask any questions or get the entire process more cleared, uh, there is a toll-free number which is provided, which is available from Monday to Friday from 10 a.m. to 6 p.m., through which you can connect and get your concerns addressed. So post this test, what typically happens is we repeat the test for 3 nights, and that's what we call as the multi-night testing. And you get a notification that okay, you have completed your 3 nights of testing. And if there is an error, it will show you an error message and take the customer to the ResMed India OST page with error details. So suppose you have successfully completed your test, uh, the, the patient will probably get the results and the link to consult a sleep coach from ResMed. And typically, the results uh, or the sleep report comes to the patient in a span of around 3 to 5 days. And you can ask me why it takes 3 to 5 days. Because although the report is generated every night, but then the cumulated report is then sent to a sleep physician who actually validates and goes through the report and actually signs off the report before sending it to the patient. So that's why there is a delay of around 3 to 5 days before getting the report. So this is how the OST report looks like. And uh, this is something which has been explained by Dr. Bijwadia, sir. So, uh, so I'm coming to the end of my presentation, and I think we can run the polling questions, which is there with the admin. And what we can do is we can take few other questions if there is any from the audience. So I'll just pause here and ask the audience to type in their questions in the chat box. So I think there is one question which has popped up, which is saying that is there any influence of beta blockers while doing this particular test?
No, beta blockers are have no problem. You can do beta blockers. Most patients have very reliable results. It doesn't affect the alpha adrenergic tone.
Sure. So there are some familiar names. So although we know that this device is for adults, at least that's what the data says. But I think Dr. Kishore is asking, what's your thought of using the device in children?
Yeah, it's not approved in children yet, so that would need a separate set of regulatory approvals. Mm-hmm. If a patient is still a child, they probably need to have an in-lab study. Sure.
So Dr. Bijwadia, you also mentioned in your study that whenever we talk of devices like Type 4, we always meant it's like a screening device. But then you also mentioned that it's more of a diagnostically Type 3 device. So can you clarify on that particular point?
Yeah, all home sleep tests, when you look at the fine print in the FDA, are basically screening devices used to help diagnosing sleep disorders, right? So there is no device that you could just do the device and automatically you get a diagnosis. It's always on the basis of clinical judgment on top of what the device analysis is, which is of course why you want a sleep physician reading the study and making sure things are done. So the fact of the matter is that the reports generated by a Type 4 and a Type 3 device are treated exactly similarly. And that's why when we say it's a Type 3 equivalent, clinically does not make a difference. So if I'm reading a report from an apnea link or a Night 1 device, whatever other device, versus a Night Owl, it's exactly the same process for me. And that's why it's sort of equivalent.
But then you get the the disposable characteristics with OneSleeptest.
Absolutely. Yep.
Right. So I think what I'll do, I'll just play the video once again. For everyone to understand, how the testing is done with OneSleeptest. And possibly by the time, if we have any questions, further questions, maybe we can take those questions.
Is snoring a part of your routine? Do you miss the freshness of a healthy sleep? Do you wish to find answers on how to improve sleep? To improve your sleep, you must learn about your sleep quality. Here's a simple, accurate, and a safe way to analyze your sleep quality. One sleep test, a small test that can bring a big difference to your sleep health. In this disposable kit, you will find one night owl sensor, 10 single night finger wraps, and one user guide that makes everything easy for you. Download the Night Owl app, enter the activation code, and you're ready for one sleep test where everything happens with minimum effort. Wrap the sensor around your finger as instructed. Keep your phone at a safe distance in the same room and sleep without any worry. Repeat this multi-night test for 3 days. One sleep test based on peripheral arterial tonometry technology provides an accurate way to diagnose your sleep health. The Night Owl sensor measures key indicators like heart rate, oxygen levels, total sleep time, and body movement to determine the risk of sleep apnea. In 3 to 5 days, you will receive a detailed report validated by a sleep physician. One Sleep Test is a US FDA-approved device for measuring sleep quality by using AASM standard for scoring. And it is the most simple, accurate, and safe way to perform diagnosis in the comfort of your home. Once you have your sleep assessment reports, you can take the next steps to sleep better. Get a free sleep consultation from ResMed sleep coaches who will guide you towards a healthy sleep. Bring home ResMed One Sleep Test today and start your journey towards a healthy sleep. Wake up to good sleep.
So I don't see any questions as yet. I think the audience have exhausted their questions. So with this, I think let me thank you, Dr. Jagdeep Bijwadia, sir, for spending your morning hours with us. I know it's 11 and a half hours difference where you are sitting
No
and where
problem.
we are sitting, and
Yeah, and if I may, let me say a hello to anybody from Nair Hospital where I trained. So any TNMCites, just a big hello from me.
Sure, sure. And sir, I think thanks so much for taking us through and also answering the questions in the most lucid manner. And of course, let me also thank the audience who have come on these evening hours, trying to learn around one sleep test and how to take it forward in their own practice. And last but not the least, I think let me thank the ResMed team, uh, the marketing and the sales team, and of course the clinical affairs team, which is present here. Plus, I think the founders of this One Sleep Test are present. So thank you so much for being with us and encouraging us. And if you have any questions, please do write to us. Please reach out to ResMed entity, the nearest ResMed entity whom you have, and we'd be happy to answer your questions. So thank you so much, and have a very good night. Thank you.
Thank you.
Yeah. Hi, Jay.